one of you for today's evening of academic fiesta. For further proceedings, I'll hand over session to Dr. Amit sir. Over to you, sir.
Thank you, Dr. Srivas. Let me set the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Maury Eggerts from Mayo Clinic, Rochester, USA. And he's going to lecture us on case-based discussion on AL amyloidosis, difficulties in diagnosis and management. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Maury Eggerts from Mayo Clinic, Rochester, USA. All our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing the Saturday evening, morning, and afternoon. Tomorrow, that is 3rd of December 2023, Sunday, from 11:30 a.m. onwards, we have a webinar on difficult anemias in children, the role of NGS in diagnosis, by our own guest speaker, Dr. Anand Prakash from St. John's Medical College Hospital, Bengaluru. Let me introduce our discussants for the day, here displayed in alphabetical order. To start with, we have Dr. A.K. Ganju from American Oncology Institute, Nagpur, Dr. Gunjan Loni from Wockhardt Hospitals, Nagpur, Dr. Mahesh Rajashekara Rai from Sparsh Hospitals, Bengaluru, Dr. Mangesh Kamat from Helios Cancer Clinic, Bengaluru, Dr. Neha Ganju from Ganju Hematology Clinic and Hospital, Nagpur, Dr. Nilesh Vasekar from Nashik Hematology Services and Ashoka Medicover Hospital, Nashik, Dr. Nishad Dhakate from SCG NCHRI Cancer Center, Nagpur, Dr. Rahul Arora from RST Hospital, Nagpur, Dr. Sriram Kane from Dr. Kane Clinic and Hospital, Nagpur, Dr. Sudarshan Pandit from Ashoka Medicover Hospital, Nashik, Dr. Vishwadeep Khushu from AIIMS, Nagpur. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Maury Eggerts from Mayo Clinic, Rochester, USA. Dr. Maury Eggerts is professor at Division of Hematology, Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota, USA. He's a member committee on training at American Society of Hematology from 2015 till present. He's a member Hematology Board Exam Committee, American Board of Internal Medicine from 2015 till present. Waldenstrom Award for Medical and Scientific Achievements in Waldenstrom macroglobulinemia in the year 2014. He was a treasurer at International Myeloma Society from the year 2011 to 2014. Mayo Clinic Rolanda Sidler and Junior Professor of the Art of Medicine honoring Dr. Michael Brennan from the year 2010. He's also the President, Mayo Staff Officers and Counselors at Mayo Clinic in the year 2005. And today, he's going to lecture us on case-based discussion on AL amyloidosis, difficulties in diagnosis and management. Well, thank you so much. Over to you, Professor.
Thank you, Dr. Khurana. Let me share my screen and we'll get started right now. And a little more. Full screen, and we'll get started talking about managing amyloidosis and making a correct diagnosis. And we'll focus on a number of cases here. Our objectives are going to be clinical recognition of the diagnosis and current unmet needs. One of the great problems with amyloidosis is the fact that a delay in diagnosis will result in death or hospitalization in a high proportion of patients. If you look at some of the data that's been published from the Optum database, you can see that the mortality with AL amyloidosis is 25% at 1 year, and that over half will be hospitalized or dead in the first year over the age of 65, and will be a quarter of patients will be hospitalized or dead within 100 days under the age of 65. And all this is usually due to diagnostic delay resulting in end organ failure before recognition. So because this is case-based, I'm going to be discussing 4 specific patients that I've seen to illustrate the issues that hematologists need to be focused on. This woman had a monoclonal IgA kappa protein that was detected some years ago. When she was seen by the hematologist, she had no anemia. Her M spike was 13 grams per liter or 1.3 grams per deciliter, relatively small. Her quantitative IgA was less than 2,000 milligrams per deciliter. Her kappa to lambda light chain ratio was less than 4. A 24-hour urine was not measured, and this was a diagnostic mistake because although a urine is not required for the diagnosis of MGUS, MGUS is a diagnosis of exclusion after you rule out everything else. But in any case, this patient had a small monoclonal protein and had no CRAB criteria: normal calcium, normal renal function, normal bones, no anemia, and was told she had MGUS. She came to Mayo approximately a year later, and she still had no CRAB criteria. And when you took a history to find out what was the problem, the first problem was weight loss, nearly 30% of her body weight. She had peripheral neuropathy. She had recurrent syncope due to autonomic neuropathy. She had intractable diarrhea, and she had a low systolic blood pressure. So here you have a patient who has all types of problems: weight loss, peripheral autonomic neuropathy, hypotension, but no CRAB criteria. This patient repeatedly was told she had a stable MGUS. But when she came, we did a fat aspirate on the left showing green birefringence, a lip biopsy in the middle that showed clear evidence of amyloid in the vessels of the lip submucosa, and her bone marrow biopsy showed amyloid in the blood vessels. And this turned out to be mass spec lambda, but she died 3 months later because the diagnosis was delayed due to a failure of recognition that amyloid can occur in the setting of MGUS and not just multiple myeloma. Case 2. This man was seen for a very small A kappa monoclonal protein. His bone marrow had 5% plasma cells, no bone lesions, no anemia. So here again, a patient with CRAB, no CRAB, who was actually placed on a trial of smoldering myeloma between lenalidomide and observation, was randomized to observation, and over 2 years, the monoclonal protein remained stable. No CRAB developed in the setting of smoldering myeloma. He came to Mayo because of a rising creatinine level, which was attributed to diabetes. Kappa-free light chain showed 46 milligram per deciliter with a ratio of 15. His urine showed 3.2 grams of protein per day, but the key diagnostic test in this setting was the urine protein electrophoresis. The urine protein electrophoresis showed that the urinary protein was almost all albumin. And in myeloma and in light chain MGUS, the electrophoresis should show predominantly light chain migrating in the beta or gamma region. This patient had almost all albumin, which in the setting of a monoclonal protein should raise either kappa light chain deposition disease or kappa AL amyloidosis. So once again, you have a patient who was smoldering myeloma who actually had renal amyloidosis. And in addition, he had biomarker evidence of cardiac involvement, and the subcutaneous fat was filled with amyloid. So that's your second patient. Here's a patient who underwent a tonsillectomy. You can see that she still has a surgical hood on her head. She came out of the OR after her tonsillectomy like this. And as you know, when a person undergoes general anesthesia, the eyelids are taped closed. And when the anesthesiologist removes the tape, this is what was found. She has intense purpura of both eyelids. A hematologist was called to the postoperative recovery, saw this, ordered a prothrombin time, a PTT, fibrinogen, and fibrin split products. This patient was told she had no coagulopathy and was reassured that this was benign, no problem. I saw her 6 months after this, and she had 90% plasma cells in her bone marrow, and she had almost 5 grams of light chain proteinuria with multiple myeloma. And so she underwent induction and autologous transplant, and she's alive at 8 years. So here again is failure to recognize simple periorbital purpura. And although I don't have a slide, you should be aware that you're seeing patients with MGUS and neuropathy. And these MGUS neuropathy patients, you may be treating with rituximab or plasma exchange or IV gamma globulin, but a subset of these patients with MGUS neuropathy have amyloid neuropathy that's being missed. And so you need to be aware that the ratio of multiple myeloma to amyloidosis is about 5-to-1. So for every 5 myeloma patients you see, you should be seeing 1 patient with amyloid, and if you're not, then there's a case-finding issue. Of course, one of the clues for amyloidosis is that it's multi-organ involvement. And so the patient sees the cardiologist, and the cardiologist is not paying attention to the patient's peripheral neuropathy. Or they see the neurologist for neuropathy, and they're not paying attention to dyspnea on exertion, atrial fibrillation, lower extremity edema. Or they're seeing the gastroenterologist for diarrhea. They have colonoscopy and biopsies, but Congo red stains are not being performed. And if you look at the journey to diagnosis, the median time from symptoms to diagnosis is a year. And even though 70% of patients have cardiac involvement, only 19% are diagnosed by a cardiologist. 60% have renal involvement, only 23% are diagnosed by a nephrologist. It's hematologists that make the diagnosis most often. So we're responsible for recognizing amyloid in patients with unexplained heart failure or unexplained proteinuria. And as you can see, the median number of doctors visited prior to diagnosis is 3. With regard to the diagnosis, I just want to briefly review the requirement for mass spectroscopy to make the diagnosis. For those of you unfamiliar with the technique, let me walk you through. In A, on the left, you can see the bone marrow biopsy. You can see the myeloid elements, you can see the bone marrow fat, but in the center of the bone marrow biopsy, you can see this amorphous eosinophilic hyaline material that stains red with H and E. In B, what happens, this material, which clearly is amyloid, is viewed under polarized light, and then a off the glass slide without any frozen material, it is etched off the glass slide. You can see that a technician has drawn a red line around the material, and in the far right of panel A, you can see the tissue's been removed from the slide. It's placed into a cuvette, then it's reduced to peptides, then the peptides are sequenced by mass spectrometry. And in B, you can see the peptides comprising that amorphous material. And number 1 is albumin, which is adherent. 2 and 3 are apolipoprotein E and vitronectin C. Number 6 is serum amyloid P. So this represents a positive control. You can see the amyloid-associated peptides, apolipoprotein E and vitronectin, are always present in amyloid deposits. The key is number 4, kappa amyloid light chain. It's kappa light chain. That is identified, and in C, it's compared with a library that gives you 100% certainty that the peptide is a kappa light chain. Not only that, you can see that it's only a light chain fragment instead of an intact immunoglobulin light chain, which has a molecular weight of 25 kilodalton. In number 4, it's 12 kilodalton. And as a consequence, you can actually recognize that it's a hydrolyzed light chain that would not be amenable to immunohistochemistry, which will recognize the constant portion, which has been deleted. So once you diagnose amyloid, you certainly need mass spec to identify that it is AL and therefore the purview of the hematologist. It's important because with mass spectroscopy, only 59% of patients with amyloid have AL, 28% have ATTR, and 3% of ALEC2. And ALEC2 is an important cause of renal amyloid. It's found in relatively high prevalence in Punjabi Indian. And so a patient from India with nephrotic syndrome showing amyloid, that may not be AL, and you need mass spec to exclude ALEC2. This is a head-to-head comparison of immunohistochemistry and proteomics. And immunohistochemistry will be nonspecific in nearly a quarter of the patients, where in patients who get proteomics, the inability to make the diagnosis is only seen in 6%. Proteomics is far more sensitive, and actually, in some instances, immunohistochemistry can be misleading, telling you it's a certain type of amyloid incorrectly. With regard to renal amyloid, just a reminder that when you see renal amyloid, it isn't always AL. It could be light chain or heavy chain amyloid, but it could also be ALEC2 or secondary amyloid or fibrinogen amyloid, and this needs to be distinguished. With regard to the prognosis, prognosis is determined by depth of response to your treatment, and that's measured by the reduction in the light chain. As the light chain goes down deeper and deeper and deeper, the likelihood of organ response increases, and the likelihood of survival in the upper right-hand corner improves. You can see that patients achieving a complete response, which is the blue dotted line, have the best survival of all. And unlike myeloma, where you can have patients who can do extremely well with only a partial response, patients with amyloidosis who only achieve a partial response still have plenty of light chain in the serum available to deposit as amyloid. So unlike myeloma, where a PR can be an acceptable endpoint, in amyloid, if you don't achieve a VGPR, the outcome will be poor, and the likelihood of an organ response, lower left-hand corner, is sharply reduced. There are many staging systems for amyloid, but the two most popular are the European staging system that looks at two cardiac biomarkers, troponin and BNP, brain natriuretic peptide, to stage patients, and the 2012 Mayo Clinic staging, which uses cardiac biomarkers, but incorporates the free light chain assay as a measure of tumor mass to give you an assessment of median overall survival. Please note that in the European staging, on the left, stage 3B, advanced cardiac, has a 4-month median survival, and in the Mayo staging system, advanced cardiac has a 6-month median survival. And of course, stage 4 means you didn't recognize cardiac amyloid at an earlier time point. This is the validation showing that staging does predict survival, looking at different cut points for the troponin level. And so when you're staging your patient with AL amyloid, your two most important measures are troponin and brain natriuretic peptide. Renal response, keeping people off dialysis and preventing end-stage renal failure is critically important. And in order to do that, on the left, you need to get a deep hematologic response, and you have to drive the proteinuria down more than 60%. If you do that, the patient will have prolonged renal survival, and you will prevent dialysis. And on the right, the goal of a hematologic response is to get the patient's cardiac biomarkers improved. And so you're looking for a 60% reduction in the NT-proBNP or BNP. Less than that is going to result in end-stage cardiac failure and death. A little bit on therapy. Stem cell transplant is still a valid therapeutic option, particularly where daratumumab is not easily available. And induction chemotherapy with bortezomib-based chemotherapy, followed by autologous stem cell transplantation, results in the best responses. And you can see that induction therapy results in much better outcomes with bortezomib, but also outcomes are stage related, so that earlier diagnosis in D results in a much improved outcome and survival with induction followed by transplant. Guidelines have been published for the use of stem cell transplantation in amyloidosis recently, and this is something that really needs to be kept in mind if daratumumab is not easily available. First, selection of patients to be sure that they will survive the transplant, which is driven by the extent of cardiac involvement, the extent of renal impairment, age, and performance status. Stem cell mobilization does not require chemotherapy. If the patient is a suitable candidate, melphalan remains the standard induction therapy for these patients. So just a reminder that stem cell transplant, although its use is in decline with the introduction of daratumumab, is still very helpful and can be used as consolidation in those patients who do not achieve a VGPR or better with induction chemotherapy. But it is more toxic than in patients with multiple myeloma, with the therapy-related mortality of approximately 3%, and requires a multidisciplinary team, including a cardiologist and a nephrologist. The backbone of chemotherapy for the last 15 years for amyloidosis has been bortezomib-based, cyclophosphamide bortezomib dex. Two important points on this slide. In the lower left-hand corner, you see, again, that to achieve a good outcome with chemotherapy, you need a VGPR or better. A PR is inadequate, and you'll still lose a third of patients. And in the upper right-hand corner, you see how important stage is, and that if your diagnosis is early, you will survive. But if the diagnosis is delayed, stage 3B in the upper right-hand corner, purple line, the median survival remains less than 1 year, even with bortezomib backbone-based chemo. But then daratumumab was introduced. And the first utilization of daratumumab dates back about 6 years in relapsed refractory patients, both in phase 2 trials and retrospective case series. And daratumumab demonstrated high response rates, anywhere from 60 to 100%, with high complete and very good partial response rates ranging from 50 to 86%. So it was clear in the refractory relapse setting that daratumumab had significant activity, and so it was brought forward into the Andromeda study to look at treatment-naive patients. So this was a randomized study of bortezomib cyclophosphamide dexamethasone with daratumumab, bortezomib cyclophosphamide dexamethasone, in patients with organ involvement with AL amyloidosis and an eGFR greater than 20, but an NT-proBNP less than 8,500. And the endpoint was survival or major organ deterioration, meaning dialysis-dependent renal failure or renal transplantation or cardiac transplantation or the placement of an LV assist device into the left ventricle. And when this was done, updated at 20 months, you can see that the CR or better rate with daratumumab was 59% compared to 19% without daratumumab, a nearly threefold increase in the CR rate. And of course, developing these deep hematologic responses are necessary, although not sufficient, for the development of an organ response, which of course is our goal. And the responses occur very quickly with daratumumab, median of 2 months. When you look at different response criteria, and there are many different response criteria, the study endpoint on the left, but the International Society of Amyloidosis has defined criteria. And then there are criteria that look at the difference between involved and uninvolved light chain being less than 20 milligram per liter, or the difference between that the light chain involved is less than 10 milligram per liter. All of them show at least a doubling of hematologic response with daratumumab. And this response, hematologic response, does translate to improvement in cardiac function. So cardiac response, here defined by a 30% reduction in the BNP, was doubled from 28 to 57% at 12 months. And likewise, renal response rates were doubled at 12 months from 27 to 57% with the addition of daratumumab. But of course, this requires accurate recognition of the diagnosis before advanced renal and cardiac symptoms develop. One of the problems with the Andromeda trial is that it excluded patients whose NT-proBNP was greater than 8,500. So there was a knowledge gap about, well, does daratumumab-based therapy help if you have advanced cardiac amyloid with an NT-proBNP greater than 8,500? And a multi-center European myelomonetric trial looked at daratumumab with advanced cardiac disease, and although their survival isn't nearly as good, when compared to historic controls, the 12-month survival rate was 47%, when in fact we would expect at 12 months only about a quarter of patients should still be alive. So all patients probably deserve a trial of daratumumab-based therapy, even if they have advanced cardiac disease. This is just a look at these patients who had advanced cardiac, but also had kidney and liver involvement. And these patients did develop responses in 35% of other organs if the heart was involved. And so there's a collateral benefit to the kidney and the liver with daratumumab, even with advanced cardiac involvement. One thing to note is that genetics are important in AL amyloidosis, particularly the 11-14 translocation, which, unlike multiple myeloma, is present in approximately 15% of patients in myeloma, is present in almost 50% of patients with AL amyloidosis. And this demonstrates that these patients are bortezomib resistant with 11-14. They don't do as well with bortezomib, although they do fine with daratumumab. But it's an important thing to remember, because in any patient with a plasma cell dyscrasia who has the 11-14 translocation, you will expect them to have increased expression of BCL2. And that suggests that patients with amyloid and 11-14 will be sensitive to venetoclax. And so venetoclax is an important second-line consideration in patients with 11-14. And you can see in this case series that at doses of only 400 milligrams per day, complete responses and very good partial responses are common. with nearly half of the patients continuing therapy at the time that this was published. So venetoclax in the 50% of 11-14 is an effective second-line therapy. But that's not enough. Even with effective chemotherapy, we can reduce the plasma cell burden and we can reduce the light chains. But currently, we don't have any way to remove amyloid deposits deposited in tissue. So patients with advanced cardiac disease still will go on to die because of a late diagnosis. Because when end organ damage is severe, even elimination of the clone from the bone marrow may not allow adequate time for healing. So we need treatments that not only target the plasma cell and reduce production of the immunoglobulin light chain, we need to get rid of the amyloid deposits. The first of these was an antibody that was developed in the University of Tennessee called KALE 101. And from this blood publication in their phase 1AB study, they used this antibody in patients with AL amyloidosis, and they demonstrated as a single agent without chemotherapy that there was nearly a 60% cardiac response rate, defined by a 30% reduction in the NT-proBNP, driven by KALE 101. And so this has completed accrual, this antibody, in a phase 3 trial of KALE plus chemotherapy in treatment-naive patients with cardiac amyloid compared to chemotherapy alone. We expect a readout as whether this antibody improves survival in cardiac amyloid within 18 months. The second antibody is bertamimab. And what you're looking at is incubated macrophages with amyloid deposits. On the left, there's a IgG control that's been added, and you see nothing going on other than Brownian motion of macrophages. But on the right, you can see the amyloid deposits, which when they're engulfed by macrophages turn red. And you can see multiple macrophages on the right engulfing the red deposits of amyloid and subsequently catabolizing and dissolving them. So bertamimab neutralizes and disaggregates soluble amyloid as well as insoluble amyloid fibrils. A post hoc analysis of patients who with Mayo stage 4 who received bertamimab plus chemotherapy compared with chemotherapy, and this is actually published now in Blood 2 months ago, showed that the survival improved at 9 months from 49 to 74%. And this trial, bertamimab plus standard of care chemotherapy versus standard of care chemotherapy in Mayo stage 4 cardiac amyloidosis, is actively accruing at this time as a registration trial for bertamimab for cardiac amyloidosis. Bertamimab, in addition to improving survival, improved quality of life. On the left, you can see the quality of life questionnaire SF36, and you can see that people who received chemotherapy only in yellow had a significant decline in quality of life. People that received bertamimab and chemo had only a very mild reduction in quality of life. And the 6-minute walk test, a measure of cardiac functional performance, deteriorated significantly in people receiving chemotherapy, yellow on the right, compared to the blue, where 6-minute walk test improvement actually was better. Both of these achieved statistical significance. So you get an improved survival, improved quality of life, and improved performance by walk test. I want to leave a lot of time for discussion, so I just want to touch base on how we approach the diagnosis of amyloid. So if you have a clinical suspicion of amyloid, meaning you're seeing a patient with heart failure, preserved ejection fraction, smoldering myeloma with weight loss or neuropathy, Mugus neuropathy, proteinuria with an elevated light chain. You do serum immunofix, urine immunofix, and a free light chain assay. Now, this is important because if there's no monoclonal protein, it's very unlikely that you have AL amyloidosis. And the second most common on the right is TTR amyloidosis. TTR can be diagnosed using pyrophosphate imaging of the heart. And if it's positive, TTR is very, very likely. If it's negative, however, then you have to have a high clinical suspicion. You do a biopsy. But you have to remember, anytime you make a diagnosis of amyloid, you need mass spectroscopic analysis of the protein to distinguish AL from ATTR from ALEC2. If a monoclonal protein is present, our recommendation would be a bone marrow biopsy and a fat aspirate, possibly a lip biopsy. If it's negative, those three, the chance of amyloid is only 15%, so you don't want to do any more unless your index of suspicion by echo or by the urinary protein pattern is very high. You don't want to pursue it. If a bone marrow or fat or a lip biopsy is positive and mass spec shows it to be AL, daratumumab-based chemo would be the first thing. You also have to be aware that some forms of amyloid are localized and do not require systemic therapy. Common sites of localized amyloid are bladder, ureter, skin, larynx, bronchus, trachea. Those, if you see those, you're never sure. In addition, localized amyloid is frequently seen on the edge of colonic polyps and on the edge of colonic ulcers. These are degenerative and are not indicative of systemic amyloid. To see amyloid, you also have to think about localized versus systemic. Now I'm going to go over our treatment recommendations based on Mayo Clinic's MSMART guidelines. In the transplant-eligible patient, we would begin with daratumumab, bortezomib, cyclophosphamide, dexamethasone. We need at least a partial response by 2 months, but you need a VGPR at the end of 4 cycles. If you achieve it, we don't think that you need to do a transplant. Those patients can be observed. But if you don't, then you have to consider stem cell transplantation for those patients who don't achieve a deep response. If otherwise, if they do get a transplant and they don't achieve a VGPR, they have to go to second-line therapy, which I'll discuss momentarily. If you're transplant ineligible, we again would recommend daratumumab VCD. Again, our requirement is a hematologic PR by 2 months and a VGPR by 4 months. If you achieve those goals, we would recommend 6 cycles of induction of all 4 drugs and then maintenance daratumumab for an additional 18 months. If you don't achieve a VGPR by 4 months, we move to the next. And this is the relapsed refractory algorithm. And the way we treat patients who failed treatment depends on whether they've failed daratumumab or not. So if they're daratumumab naive, you give daratumumab. If they're not daratumumab naive and they failed, you have to ask, can we transplant? And if they can be safely transplanted, you transplant. But if they're not transplant eligible and have failed daratumumab-based therapy, then the next question is 1114 present? Because if it is, we'll recommend venetoclax. But not transplant eligible, not daratumumab, and not 1114, our recommendation would be an immunomodulatory drug such as pomalidomide or lenalidomide. There are options in patients who've been previously transplanted for a salvage transplant. Carfilzomib has been reported, but can be difficult to give in patients with cardiac amyloid because of dyspnea, because of cardiac rhythm disturbance is seen with carfilzomib, and there have been reports on the activity of bendamustine in patients with refractory amyloid. And so with that brief overview, I'm going to stop sharing my screen and I will turn it back over to your discussants. And thank you very much, Dr. Khurana, for the invitation.
Thank you, Professor Bori Guts, for that wonderful update on amyloidosis. It was fantastic and superb. I now request all our Indian colleagues and discussants to please put the raise hand sign so that we can start our question session with Dr. Guts. Yes. Anybody? Dr. Nilesh? So in the meanwhile, when the questions keep on coming, so regarding the role of mass spectrometry. So are you able to hear me?
Oh, perfectly.
So yes. So regarding the role of mass spectrometry in the case of AL amyloidosis, we don't have that facility over here in India yet. So is there any way that if we are suspecting the patients, and subtyping is very much important once we diagnose a case of amyloidosis? And if yes, is it required that we must go for mass spectrometry for all the patients of amyloidosis?
Well, just a couple of things to just keep in mind. I mean, if you have a patient with amyloid and you have a light chain level that's 10 times normal in the correct clinical setting, it's likely to be AL amyloidosis. But cardiac amyloid, it's very difficult clinically to distinguish AL from ATTR. It's very, very difficult. And one of the problems that you get with immunohistochemistry, which is the standard in many laboratories, is that because the light chain in AL amyloid is a fragment, it's truncated, it loses the constant portion of the immunoglobulin light chain. And almost all commercial anti-sera only detect the constant portion of the light chain. Secondly, the light chain in amyloid, as you know, is a misfolded protein. And this misfolded protein can hide the epitopes that are normally exposed for commercial anti-sera. Finally, there are so many different types of amyloid: AL, ATTR, AH, A-beta-2 microglobulin, ALEC2, A-fibrinogen. Nobody has a panel of anti-sera broad enough to identify all the different subtypes of amyloid, and that's not a problem with mass spec. And so, look, if you don't have mass spec, you don't have it, and that's unfortunate. And if it's possible, if your immunohistochemistry is strongly positive, then it's probably reliable and it tends to be good. But there are times where I've seen mass spec diagnose AA and ATTR, and it was wrong. It was just completely misleading. And so it's difficult, and there are some risks if the clinical situation is ambiguous and you don't have access, which I realize it's limited access and it's extremely expensive, which obviously that makes it undesirable, but it's still the gold standard, unfortunately.
Thank you, sir. One question from Dr. Gopinathan. He is a patient of nephrotic range proteinuria. Creatinine is 2.1. Serum protein electrophoresis and serum protein immunofixation both are negative, but minimal kappa skewing. The ratio of the ratio of plasma cells, the amount of plasma cells in the bone marrow biopsy is 3%. Renal biopsy shows AL amyloidosis. What would be your line of management? And the kappa lambda ratio is 2.5.
Right. So as long as there's clonal plasma cells, as long as that 3% plasma are definitely clonal kappa, we need to be sure, because with serum and urine immunofixation negative, you're a little bit suspicious. Yeah. If the kappa is only minimally elevated, That could be due to renal insufficiency because light chains are excreted by the kidney and it'll give you an elevated kappa. So you have to just be concerned. But if those plasma cells are absolutely clonal, then it would be daratumumab, bortezomib-based chemotherapy. Creatinine 2.1 probably unsafe for a stem cell transplant. I'd also want to be sure for AL that there's nephrotic range proteinuria, because the absence of proteinuria in renal amyloid would make you think of non-AL. But again, there's caution because over the years I've seen patients referred with kappa minimal elevation, polyclonal plasma cells in the bone marrow, and they turned out to have afibrinogen, ALEC2, and not AL. So you just caution before you give chemotherapy to just be sure that we're confident about that AL diagnosis.
Thank you, sir. Dr. Nilesh, you have a question?
Yeah. Hi, Professor. That was a nice presentation, and could learn a lot of things about amyloidosis from that. So I have a patient of light chain amyloidosis, sir, and he is a 42-year-old male, and he has received 4 cycles of VRD. Followed by that, there is a hematological remission, but his NT-proBNP is in the range of 6,000 to 7,000. Should I take him for an autologous transplant or should I wait?
In this situation, a lot of it depends on his systolic blood pressure. That's very, very important. If his systolic blood pressure is over 110, he probably has enough functional reserve to be consolidated. If he's running a blood pressure of 80 to 90, I'd be very, very reluctant. The other thing I would be interested in is his troponin level. If he had a high sensitivity troponin T of over 50, I'd be quite concerned. That's a lot of cardiac cellular injury, and I would be reluctant to take him to transplant because the mortality is going to be 10%. But if he has a decent systolic blood pressure and not significant elevation, if he still has persistent NT-proBNP at 6 months, I'd be inclined, unless the one exception is the bone marrow is MRD negative. If the bone marrow is MRD negative, I'm watching.
Okay, sir. Thank you so much.
Thank you, sir. Thank you, Dr. Nilesh. Dr. Sumit Mik has a question. If patient achieves CR after 6 cycles of DARA, SIBO-D, what is the role of DARA maintenance?
That's not clear. I mean, DARA maintenance, it's uncertain. And of course, it's extremely expensive, and the optimal duration of daratumumab is unclear. In the Andromeda study, at the end of 6 months, patients received an additional 18 months of DARA maintenance. So that's what the trial showed. That's the only data we have. Currently at Mayo, we actually have a randomized trial now where we're randomizing patients who are responsive at 6 months to either 6 months of DARA or 18 months of DARA to try and determine if we can do just as well by stopping DARA at 1 year. But it's a clinical trial, and the only data we have that's published is the Andromeda trial, which says 2 years. But you're quite correct in raising the question, do we really need that much? It's unknown.
Thank you, sir. Another question from Dr. Sin Win. She has got a case where, she has a question that which of the following, that is renal, lip, subcutaneous fat, or rectal biopsy, which one has got the highest yield for amyloidosis, and which one is the safest?
Right. So here's the thing. It requires a fair amount of experience on your pathologist. Congo red, I'm afraid, is not the simplest stain. And Congo red can be overstained and understained. And so experience becomes important. I'll tell you that for me, the bone marrow is the easiest because in a patient with a plasma cell dyscrasia, you're doing a bone marrow anyway to exclude multiple myeloma. But the yield, even in experienced laboratories, is only 50%. But if it's 50%, you can stop. The second most common is subcutaneous fat, but subcutaneous fat requires operator experience as well, because it's an aspiration, it's not a biopsy. So it's not paraffin embedded, it's not sectioned with a microtome, which is what pathologists are used to. You take the fat and you just crush it between two slides, formalin fix and stain. And so pathologists are not used to seeing Congo red. We can talk about the sensitivity of fat, which in our hands is 75%, but they may not translate into another lab. But it's easy because you can do it on anybody. You can do it in atrial fibrillation patients who are anticoagulated. Lip biopsy has the advantage is that it's extremely non-invasive, can be done on anticoagulants, is paraffin embedded and sectioned, and Congo red stained. Those all run about 70 to 75% positive. But I think requires a discussion with the pathologist about what kind of tissue they want to see, what they're used to seeing, what they're experienced. If they've never seen a fat aspirate before, it's not very fair to do a fat aspirate, send it and say, please interpret this for me. And so I'm afraid that on this one, it's a phone call to pathology saying we're looking to establish non-invasive biopsies for amyloid. Here's our choices: marrow, fat, lip, rectum. And what would you prefer? Now, I will tell you about the rectal biopsy. We've stopped doing it at Mayo. And the reason is when we first published on the rectal biopsy, those rectal biopsies were done with the rigid proctoscope, the old 25 centimeter proctoscope. And we would use the rigid biopsy forceps, and we would get a good biopsy with submucosa. With flexible sigmoidoscopy, the biopsies are much less deep because that's what's required through the flexible sigmoidoscope. Sometimes you just get mucosa. And if you don't get submucosa, you don't get blood vessels. And if you don't get blood vessels, it's pointless to stain for amyloid because the amyloid's in the vessels, in the submucosa. So if you can get rectal biopsy with submucosa, it's 80% yield. And of course, endoscopists are very, very experienced in doing this. It's a question of biopsy depth.
Thank you, sir. Another question from Dr. Nidhi Jain. Role of kidney transplant in patients who have achieved CR post-DARA VCD.
Oh, yeah. So that's a very important question. And those publications are coming out quite rapidly. And the answer to that is these patients are absolutely eligible for renal transplant. If the patient does not have extra renal amyloid, I mean, we're not giving a renal transplant to someone who's got an NT-proBNP of 6,000 and an echocardiographic septal thickness of 15 millimeters. But if it was only renal, dialysis-dependent renal failure, a complete response to daratumumab-based therapy, and an available donor, we absolutely would proceed with renal transplant. Renal survival is excellent, and the ability to keep the light chain suppressed long-term with DARA, bortezomib, even lenalidomide is legitimate. And so these patients for sure are candidates, but you really do need that complete response. And of course, the stipulation that no significant organ involvement outside the kidney.
Thank you, sir. Another question from Dr. Deep Gala. He has a case of amyloidosis and is in VGPR right now. And now the patient has got recurrent bilateral pleural effusion with asymptomatic hypotension with a normal ejection fraction. The cardiac MRI shows only transmural enhancement around left ventricle. All other workup has turned out to be negative. What could be the possibility etiology for this, and how can we proceed further?
This absolutely is going to be cardiac amyloid. These recurrent effusions are common. This is a patient who has advanced cardiac amyloid. Ejection fraction doesn't mean anything in amyloid because the problem isn't the pump. The problem is filling. There's diastolic failure. And so what's happening is during diastole, the left ventricular chamber isn't filling with blood. I mean, it just isn't because the pressure rises so fast, filling stops. So what happens is during the beat, what ends up happening is the squeeze is very, very good, but the end diastolic volume is low. So what you end up is a normal ejection fraction. It kicks out 60% of a low end diastolic volume. That low end diastolic volume means low systolic blood pressure. That's why the systolic pressure is low. The high filling pressures are why the patient has pleural effusions, because it's on the right. The EF is, you just ignore that completely. The MRI is right. There is enhancement. This is advanced cardiac amyloid. And if you check the NT-proBNP, this patient with pleural effusion, it's going to be 10,000. And if you check the troponin, it's going to be over 70. I mean, that's been my experience. This is advanced, unfortunately, advanced cardiac amyloid. Despite the hematologic response, the degree of organ dysfunction remains severe.
True, sir. Thank you so much, sir. Another question from Dr. Nidhi Jain regarding the cardiac organ response. If NT-proBNP level is decreased from, say, 30,000 to 5,000 after treatment, can this patient be safely taken for stem cell transplant if left ventricular systolic function is absolutely normal?
Yeah, so 5,000 still a little bit up there, and I would be making the decision based on performance status. I mean, is the patient coming to your office in a wheelchair or coming to your office ambulatory? Systolic blood pressure for me is a big, big deal. I'll elaborate on that in a moment. And the troponin level, because that level is really a good predictor of early mortality after stem cell transplant, because it reflects cardiac cellular injury, just the way it does with ischemic disease and myocardial infarction. But just a comment about why systolic blood pressure is important. As you all know, with transplant, at least half of the patients will develop neutropenic fever, either culture negative or culture positive. They'll develop febrile neutropenia. In a non-amyloid patient, as they develop fever, as you know, their peripheral resistance drops. And of course, what happens for most myeloma patients being transplanted is they just increase their cardiac output, they increase their pulse until antibiotics finally resolve the neutropenic fever. But if an amyloid patient has a systolic pressure of 85 baseline and they develop neutropenic sepsis, their blood pressure falls to 60, 70, they hypoperfuse, they develop lactic acidosis. You know how that ends when that happens. And so if they have enough pump function to get their blood pressure over 100, you probably can proceed safely if the troponin's not too high. But if their systolic pressure is lower, their performance status, if they can't walk 100 meters to your office, this is not a patient I'd be very excited about taking the stem cell transplant.
That was a fantastic answer, sir. Wonderful. Another question from Dr. Nikhil. What would be your line of management of AL amyloidosis with predominant liver involvement?
That's a great question. About 15% of patients have some degree of liver involvement, but only 5% have exclusively liver involvement. That manifests with significant hepatomegaly and a very dramatic elevation of alkaline phosphatase. Those patients can be transplanted if their ALK phos is less than 5 times normal and their bilirubin is less than 2. But the standard for me still would be daratumumab, bortezomib, cyclophosphamide, dexamethasone, trying to get them to respond. The primary response parameter is the alkaline phosphatase. These patients frequently have pretty serious nutritional issues. These patients with liver amyloid have terrible anorexia, very common to lose 10% of their lean body weight. You go with chemotherapy, it's just interesting. These patients actually do have a pretty decent response rate. We can't show them in the trials because there's only 5% of the patients who have liver involvement, but they actually do respond quite nicely to chemotherapy because the liver has a massive capacity to hold amyloid, and liver can be 10 centimeters below the right costal margin and still have minimal enzyme abnormalities. They're good candidates for chemo, and they can be transplanted if the ALK phos and bilirubin aren't off the chart.
Thank you, sir. Another question from Dr. Belkin Nadil. When do you recommend actually screening for AL amyloidosis?
Repeat it, please, Dr. Khurana.
In which patients do you recommend screening for AL amyloidosis?
Sure. So this is a discussion that you have to have with your cardiologist, nephrologist, neurologist, because you're not seeing these patients initially. But for the cardiologist, the big mistakes are heart failure, preserved ejection fraction, hypertrophic cardiomyopathy. They see the thick walls, they say it's hypertrophic. Hypertensive cardiomyopathy without a strong history of severe hypertension. So those three, there's a lot of heart failure, preserved ejection fraction out there, and the cardiologists have not put in their workflow, they haven't put light chains. And all you need is a light chain assay, because the light chain assay is abnormal. There's not a big differential diagnosis, but they're not doing light chains. I've seen these patients seen with thick walls, and the cardiologist does a ferritin looking for hemochromatosis, but not a light chain looking for another form of infiltrative cardiomyopathy. So it's HFpEF, hypertrophic. Those are the big ones. For the nephrologist, it's every patient with nephrotic syndrome. You've got to do the light chain. I've seen these patients called nil disease, minimal change glomerulopathy, get steroids for 6 months, no response, simply because they didn't do the light chain. I've also seen notes from the nephrologist with nephrotic syndrome, and they write differential diagnosis, minimal change, membranous, membranoproliferative glomerulopathy. Over the age of 60, non-diabetic, 10% of those renal biopsies are amyloid, but they're not putting amyloid in their thought process, in their differential diagnosis. Neurologist sees patients with monoclonal gammopathy and neuropathy with a red flag, bilateral carpal tunnel syndrome, or autonomic involvement, orthostatic hypotension, diarrhea, unexplained weight loss. They're getting IVIG, they're getting plasma exchange, but they didn't actually look for amyloid. It wasn't in there. And finally, in your patients with MUGUS and smoldering myeloma, looking for things like weight loss, which is not part of CRAB, diarrhea, not part of CRAB, checking the urine for protein, because a MUGUS patient shouldn't have proteinuria, and a smolderer shouldn't have over 500 milligrams of proteinuria. It's relevant. And occasionally, if the patient has fatigue, unexplained MUGUS or smoldering, get an NT-proBNP and troponin. Those are your big classes. It would be the cardiacs, the renals, the nerve, and the smoldering myeloma MUGUS.
Thank you, sir. Another question from Dr. Nikhil. If AL amyloidosis has been detected very early without any significant organ involvement, can such patients be taken straight away to upfront stem cell transplant without induction chemotherapy?
Well, it kind of depends on how you got the diagnosis of amyloidosis. I mean, if patients have no organ involvement at all, I don't know that I'm treating them. I'm monitoring them. But if they have mild organ involvement, certainly we used to take them directly to stem cell transplant because the bone marrow was 3% plasma cells or 5% plasma cells. But the reality is that the Chinese in a phase 3 trial have demonstrated that bortezomib-based induction does improve the outcome. And of course, that's what we would do in multiple myeloma. We would do 4 months of induction followed by transplant. So we tend to do induction followed by transplant, although for years we did transplant only. The data is suggesting it might be better to induce first and then go to transplant.
Thank you, sir. Another question from Dr. Sumit Mirk. Apart from renal involvement, any other organs which are affected by ALEC2?
No, that's a great question. ALEC2 appears to be pretty exclusive to the kidney, and what's unique about it is that it does cause renal failure, but not much proteinuria. The deposits don't tend to be glomerular, so you don't get a lot of protein leak. They tend to be mesangial and interstitial, and so the creatinine rises and the proteinuria is less than 1 gram. It tends to be renal. These patients tend to be reasonable candidates for renal transplantation. Unfortunately, there really isn't effective anti-amyloid therapy at this point in time for those patients. So the management is supportive until end-stage renal disease, and then they become candidates for transplant. But you don't expect to see extrarenal involvement with ALEC2 renal amyloid.
Thank you, sir. Another question from Dr. Sin Win. In a case of AL amyloidosis, already treated with 6 cycles of VCD, and the 24 hours urine protein falls from 23,450 to 2,234 milligram after 6 cycles of VCD. Autologous stem cell transplant is not possible as the patient is not willing. Any more cycles do you recommend as a maintenance?
No, this is a very good response. I mean, you've got a spectacular organ response. The urinary protein has fallen by greater than 90%. And so this is really excellent. And so I guess I would finish with 6 cycles and monitor. And all I can say is congratulations, because that really is an awfully, awfully good outcome.
Thank you, sir. Another question from Dr. Gopinathan. Can you please brief out some points regarding the management of known AL amyloidosis? Sure.
The most common form of systemic non-AL amyloidosis is ATTR amyloid. And ATTR amyloid, the source has nothing to do with the bone marrow or clonal plasma cells. The source of TTR is the liver. And the liver produces it, and the TTR misfolds and deposits almost exclusively in the heart, occasionally in the nerves. And there's 2 types. A wild type, where it's normal TTR, which tends to occur in elderly men. It's 90% men, 85% men. Usually the median age is 70 and up, very common in 80, 85-year-olds. In those patients, there are 2 types of treatment. One type of treatment prevents the misfolding of the TTR molecule into amyloid conformation. The 2 oral agents are tafamidis, made by Pfizer, trade name is Vyndaqel or Vyndamax. That's an oral agent that's administered daily that is shown to have dramatic improvement in survival. The other agent, which is not approved for this indication, is a non-steroidal anti-inflammatory agent called diflunisal, which is given in a dose of 250 milligrams twice daily and has been shown to improve outcomes in patients. Not approved for cardiomyopathy, but approved for patients who have inherited forms of TTR amyloid, are gene silencers. There are drugs that are small interfering RNAs, or they're antisense oligonucleotide RNAs that silence the gene, prevent TTR from being produced, and result in benefit. There's been one publication of CRISPR therapy, where the gene has been altered to become non-secretory in TTR amyloid and preventing the development of TTR. Finally, there are 2 companies that are looking at anti-TTR antibodies. These anti-TTR antibodies are investigational currently, but like bertamimab and KL101, are designed to bind to the TTR and prevent it, dissolve it, prevent it from becoming amyloid conformation. There's a form of amyloid called beta-2 microglobulin amyloid that occurs in chronic hemodialysis patients. Those patients, they get all kinds of terrible joint, tendon, carpal tunnel problems. For those patients, there's only one solution. It's renal transplant. The beta-2 accumulates due to dialysis, and if they develop it, I'm afraid the only solution is to transplant those patients. That covers the majority of patients with systemic amyloid.
Thank you,
Dr.
sir.
Khurana, do you see this chat box about factor 10 inhibition?
Yes, I just got it. Yeah. So that is a question from Dr. Vishwadip Khushu. How do you manage acquired bleeding due to factor 10 inhibition, and for how long to support?
So factor 10 inhibition, factor 10 deficiency doesn't occur with cardiac or nerve amyloid. It's only seen in renal and hepatic, mostly hepatic. and it's due to direct binding of factor 10. It's absorbed from the circulation into the amyloid deposits. And the only solution is effective therapy of the amyloid. And we've seen success both with systemic chemotherapy and transplant. Both of those can be successful. Now, you really don't get bleeding. It's like hemophilia. If the level of factor 10 is above 10%, bleeding's pretty uncommon. Just like it is with hemophilia A and B, 10% is plenty. For patients who have active bleeding, there, of course, is there's bypass activity. FEBA will work. Factor 10 concentrate does exist, and it can be used. Factor 7 concentrate will work, but these aren't given as maintenance. They're just too expensive. They're just given to carry you through active bleeding episodes. But even if factor 10 is severe, you've got to start chemo, or you have to consider a stem cell transplant early on. It's the only way to reverse the factor 10, and it does reverse quite commonly. And again, reversal doesn't mean a normal factor 10. If it's 3% and you get it to 10%, you have fixed the problem.
Thank you, sir. Another question from Dr. Hita. In transplant ineligible patients, which is the best maintenance drug for amyloidosis?
Well, that's not very well defined as to whether maintenance is even required in amyloid. Unlike myeloma, the biology of the plasma cell is extremely different. First of all, the tumor mass is much lower. Average amyloid patient at diagnosis is 5% plasma cells. Average myeloma patient at diagnosis is 30% plasma cells. So they're much, much lower tumor mass. Secondly, genetically, they're much, much better. Where in myeloma, 25% have 414, 1416, minus 17p, a duplication of 1q. You don't see that in amyloidosis. Those aggressive genetic are quite unlikely because it's really a different disease. And finally, the proliferative index in amyloid tends to be very low. They don't grow. And so there's never been any demonstrated advantage for maintenance because in reality, when we treat these amyloid, the biology is MGUS. It just happens to be an MGUS that misfolds and deposits in tissue. But once you get a response, there's never been any demonstration that continuous maintenance therapy improves outcome. Now, as we mentioned in Andromeda, people get up to 2 years of daratumumab, but even that's not proven. The only patients with amyloid that I use maintenance are those that presented with a myeloma phenotype. Occasionally you see an amyloid patient who's at diagnosis 50% plasma cells, 80% plasma cells, where you're really thinking this is myeloma-associated amyloid. In those patients, I do use maintenance like I would in a myeloma patient, and that's usually single-agent lenalidomide as my maintenance therapy. But my average amyloid patient who gets a response, who started out with 5%, didn't have bad genetics, I'm not using maintenance, I'm monitoring.
Thank you, sir. That was very clear. Another question from Dr. Sumit Mid. What is the role of anti-fibrotic drugs like batamimab when used along with induction, dara-VCD? Can we use with that?
Well, they're not commercially available. They're currently in the status of phase 3 investigations. I mean, you hope that these will be positive trials, but we don't know. But at the end of the day, if you think about it, all of the treatment that we're using for amyloid is all stolen from multiple myeloma, cyclophosphamide, bortezomib, dexamethasone, daratumumab, all stolen, venetoclax, stolen from multiple myeloma, transplant. We all took it from myeloma, but again, myeloma, the whole problem is tumor mass. That's all. You reduce the tumor mass, you stop developing bone disease, anemia resolves. But in amyloid, it's not the tumor mass, it's the light chain. Even if the tumor mass is low, if you still have light chain, you're going to be damaging organs. And all of our treatments, what does that do for the amyloid already deposited into heart, kidney, lung, liver, nerve, gut. Does nothing. All we do is stop the precursor production. Then we hope that it'll get better. But we don't do anything proactively to take the amyloid out of the tissue. So here we have the antibodies, bertamimab, KL1, and there's a new one that's just finishing phase 1, Atralis, which is AT01, all of which are looking to bind and remove amyloid. Those have a lot of promise, but again, in a practical sense, they're not available in the clinic. You have to enroll patients on clinical trials if they're available to you. And so hopefully that'll become available in our armamentarium in the future. And theoretically, it's certainly desirable to have antibodies against amyloid, but right now, trial only.
Thank you, sir. Another question from Dr. Nidhi Jain. If a patient has got a long-standing diabetes and in presence with nephrotic range proteinuria, cardiac diastolic dysfunction, SFLC suggests you of elevated lambda chains and positive with DLC of more than 100, bone marrow biopsy shows 8% plasma cells, but renal biopsy is negative for amyloidosis. Would you still evaluate for amyloidosis to rule out amyloidosis or consider this to be a MGUS with diabetic nephropathy?
Well, there are not a lot of MGUSs where the DFLC is over 100. And so, I'm hearing it and I'm thinking, well, the kidney biopsy is essentially 100% sensitive. There's no amyloid in the kidney biopsy. Kidney's not involved. But then the question comes up, is it possible, based on what was described, could the patient have cardiac AL amyloid with diabetic glomerulosclerosis? That, because you mentioned that cardiac business. And again, sure, we have a lot of MGUSs, but a lambda light chain MGUS greater than 100, they happen. But again, a lot of this is a discussion with the cardiologist. I'm talking to the cardiologist and say, well, does the echocardiogram, is it suspicious? Is there diastolic dysfunction? Is there thickening of the walls that there could be diabetic glomerulosclerosis with cardiac AL amyloid? I'm not making this decision by myself. I'm talking to the cardiologist about what their index of suspicion is based on echocardiography. If they're saying echo doesn't look much like it, I will observe without any further testing. But if they're saying, I don't know, this is an awfully thick wall, then I'm going to talk to them and say, well, maybe we need to do other site biopsies to look for AL amyloid in the heart.
Thank you, sir. Another question from Dr. Priya Darshani. A patient who has got AL cardiac amyloidosis has taken 6 cycles of SIBO-D. Now there is a hematological remission, but NT-proBNP is increasing with a trend to about 7,000. And TROP-T is also increasing. Systolic BP is 80, not affordable for DARA. What would be your next best line of management?
Well, it depends on how deep the remission is. If the patient has had a complete response, I probably wouldn't do anything. I'd be patient. Either the patient is not going to get an organ response or the organ response is delayed. If they had less than a VGPR, then I'd ask, do they have an 1114 translocation? And if they do, I'd see if I could get venetoclax. If I couldn't get venetoclax or they're 1114 negative, I'd probably try pomalidomide next. But I wouldn't do that if they have achieved better than a VGPR. So the depth of hematologic response is important, because if it's deep, you might just want to sit tight. Although, as you mentioned, with that systolic blood pressure in the 80s, it's pretty concerning that the amyloid's pretty advanced already, and it may be that nothing you do is going to fix the problem because the diagnosis was too late. But barring venetoclax and the other stuff, pomalidomide would be a consideration here.
Thank you, sir. Another question from Dr. Nidhi Jain. Amyloidosis with renal as well as GI involvement with refractory diarrhea, with autonomic neuropathy, any additional therapy to control diarrhea apart from chemotherapy and anti-motility agents like loperamide and octreotide?
Well, so you mentioned octreotide. That's an important mention that often gets overlooked. And octreotide can be useful. In refractory cases, I'll often use tincture of opium. I find that tincture of opium as an antiperistaltic agent is quite a bit stronger than the typical loperamide or diphenoxylate with atropine. And I'll use that. But yeah, that can be a really messy problem. It's very difficult, and it causes a lot of social problems for patients. And it really is difficult to control. So having refractory diarrhea is all too common a problem. So I'm sympathetic because it's very, very real, even with effective chemotherapy. But to me, octreotide is a very good consideration, and tincture of opium would be a second line.
Thank you, sir. Another question from Dr. Nikhil. How do you manage amyloidosis patients with distressing GI symptoms, intermittent bouts of severe abdominal pain, vomiting, not responding to supportive treatment, and started chemotherapy for over a month?
Yeah, so that's a problem because those patients have pseudo-obstruction typically due to the, basically they get paralysis of peristalsis in the stomach and proximal jejunum. And I'm afraid that you can't make a call after only 1 month of chemo. It's early, but I'll have to tell you that a fair number of these patients end up on central parenteral nutrition because you can't keep them hydrated and you can't keep the nutrition in these patients. And of course, the weight loss is a real barrier to getting effective doses of chemotherapy in. But there are no simple gastric emptying agents. Octreotide's been used in this situation as well. But if they can't get anything, I mean, you can try to do a jejunostomy tube and try to bypass the stomach where the emptying is occurring and try to give nutritional supplements through the jejunum. But frequently these patients have GI, they have small bowel involvement as well, and that doesn't work. And the only real solution, if available, is central parenteral nutrition.
Thank you, sir. Another question from Dr. Sinwin. In a case if you're using Lendex or Pomdex, do we use VT prophylaxis in amyloidosis also?
Yeah, even patients without IMiD exposure, they have increased VTE risk. Because amyloid patients have the purpura and they can get GI bleeding, I tend to start with aspirin as an antiplatelet agent predominantly as prophylaxis, but you do have to be on the lookout for PE and proximal VT, in which case then you need full anticoagulation. In addition, you need to be aware that there's a pretty high incidence of thrombus in the atrial appendage, in the left atrial appendage. And patients with amyloid do have a risk of stroke, even without atrial fibrillation, due to thrombus in that left atrial appendage. And of course, those patients get anticoagulated as well. And so when you're adding an immunomodulatory drug, I think then your index goes up even more, and you do need to do some prophylaxis.
Thank you, sir. Another question from Dr. Sumit. Make a patient of AL amyloidosis, known cardiac plus has myeloma. Induction would be DARA VCD like amyloid or DARA VRD like myeloma?
Not well defined. I think if there's no cardiac involvement at all, it's likely that DARA VRD is going to give you a higher response rate. I mean, the reason we use DARA VCD instead of DARA VRD is that patients with AL amyloid and cardiac involvement really tolerate lenalidomide badly. It makes their heart failure worse, their blood pressure lower, their NT-proBNP go up. And since 70% of AL patients have cardiac involvement, we try to avoid lenalidomide. But if the heart is clean, you can use VRD. And there have been studies that demonstrate VRD is better than VCD in myeloma. And so I think DARA VRD would be a better choice.
Thank you, sir. Another different question from Dr. Belkin Adil. How do you manage a case of POEM syndrome? Is it quite similar to AL amyloidosis?
No, POEM syndrome has a totally different biology. And I think that the key with POEM syndrome is if it's a single sclerotic bone lesion, just one sclerotic bone lesion, you radiate that for cure 40 to 50 gray. If it's multifocal, either Castleman's disease or multiple sclerotic lesions, you need to do everything you can to get them to stem cell transplant. Stem cell transplant is so important in POEMs that even in patients who have advanced neuropathy, cardiopulmonary problems, you really want to try to get them to transplant. Those would be your two major strategies. DARA hasn't been tested very much in POEM syndrome, but the expectation is that it will be active. But I still think your main is the linchpin, the foundation for POEMS therapy is autologous stem cell transplant.
Thank you, sir. So any discussions over here? Has got any other question? Well, sir. So I've finished all the questions from the audience, and there are no more raising signs over here. So thank you so much for that fantastic and lovely lecture, and really updating us with this AL amyloidosis. And
My
what
pleasure.
Question answer sessions. You solved so many doubts of us, and that was really great. And we are very proud to have you on board over here today, sir.
You're very kind. Thank you very much, and have a wonderful evening.
Thank you so much, sir. Thank you for joining.
Bye-bye now.
Bye.
It was a great session altogether, so it was great learning for everyone and us as well. So thank you, sir, for letting us be a part of this session today. Thank you, sir.
Thank you. Bye.